I'm Sarah Green, and I'm the Executive Officer of the Health Services Research Association of Australia and New Zealand, and we're presenting the webinar this morning. The association has been running for 20 years now. Its aim is to provide networking, education and training for health services researchers and build capacity in HSR in Australia and New Zealand. We try and run 2 or 3 of these webinars monthly. They're 3 webinars, but we do give preference to members should they get full, and we do encourage people joining the webinar to have a look at our website and our membership plans and think about joining us. Our main activity is our biennial conference, and this year the conference is being run on the Gold Coast in November, and the theme is shifting priorities and balancing acute and primary care services, and the call for abstracts for the conference is open and closes on the 9th of June. So if you're interested, again, have a look at our website and submit an abstract. We also run a number of annual awards and prizes, and the call for nominations for those awards are also open and close at the end of July. And again, details are on our website. So please have a look and think about self-nominating or nominating somebody you know that deserves recognition in the HSR field. We also have a mentoring scheme for early career researchers and a regular bulletin of health service news, careers and events. So please just take the time to have a look at our website and think about joining us. It's Catherine, who's going to talk later, will tell you it's a great opportunity, particularly for early career researchers, to get involved in a national association and meet and network. So this morning, our speakers are going to talk for about 40 minutes, and then we'll have time for Q&A at the end. Now, delegates can't speak, but you should be able to hear and see everything that's going on. And at the bottom of your screens, if you use your mouse, you'll see there's a Q&A button. So if you have questions for the speakers, if you type your questions in there, what we'll do is take them all at the end of the presentations, and we'll relay them to the speakers, and they'll hopefully answer them. And if you've got any other issues arising from the questions, you can type in more more questions, and we'll follow up as well. We're recording today's session, and I'll have that available in about a day, and I'll send the link round to anyone who's registered today, and it'll be up on our website as well. Catherine Harding, who's an ordinary member of our executive committee and is a senior research fellow at Allied Health, is going to chair today's meeting. So I'm going to switch myself off and pass over to Catherine, and she'll introduce our speakers.
All right, thanks, Sarah. Yeah, as Sarah said, I'm Catherine Harding. I work with the Allied Health Clinical Research Office here at Eastern Health, and I've also been involved with the association for quite a number of years now, particularly around activities for early career researchers. Yeah, so certainly can reinforce all of Sarah's previous messages. I'm really pleased to be chairing the session today, looking at weekend allied health services and rehabilitation. Our speakers today, Nicholas Taylor. Nick is a professor of allied health. He holds a joint position here at Eastern Health between Eastern Health and La Trobe University. He also leads the Allied Health Clinical Research Office here. The focus of Nick's research is on improving rehabilitation outcomes, both in effectiveness of specific interventions and in the way that services are delivered. He's more than 200 peer-reviewed journal publications and has certainly been a very influential researcher in my career too. Natasha Brusco is the Chief Physiotherapist at Cabrini Health. She completed a PhD in 2015 involving a randomised trial in inpatient rehab setting examining weekend services, which is what you're going to hear about today, including a cost-effectiveness economic evaluation. Tasha's PhD thesis was recognised for its outstanding merit at La Trobe University, being awarded the Nancy Millis Medal for Excellence. Tash has multiple additional roles at Cabrini, including Research Fellow and the Manager of Education and Quality for Allied Health and Ambulatory Services. In addition, she's an adjunct senior lecturer and honorary researcher at La Trobe University for the School of Allied Health. So as Sarah said, throughout the session, you're welcome to type questions. At the end, we'll be going through those questions, and we may not get to all of them, but we'll try to address as many as we possibly can. Time to hand over to Tash, who's going to start us off today. Thanks, Tash.
Thank you, Catherine, and welcome to the webinar. Just to set the scene, we had a little symbol up the top of the Hobbit, and this reminded us of our journey, which was there and back again. The journey started in 2004 when the Angliss Hospital, part of the Eastern Health Network, received state government funding to expand its rehabilitation services. Staff across different levels worked together to plan and design the expanded services. Part of the discussion was around what should or should not be offered over the weekend in terms of a rehabilitation therapy service. At the time, neither management nor clinicians could answer the question posed: should an acute rehabilitation unit provide a weekend rehabilitation service? Under the leadership of the physiotherapy manager, myself, this led to 2 preliminary studies. As with all good clinical questions, the first step was to review the literature. Therefore, the first study was a systematic review of the literature that examined the effect of additional physiotherapy outside of regular business hours. Yet the findings were inconclusive, with limited and generally poor quality literature available. Therefore, we were unable to answer that question posed. The second step was to complete a pilot study. Strong pilot data from 262 patients about providing Saturday physiotherapy rehabilitation. It may reduce hospital length of stay without compromising patient clinical outcomes, but there was only short-term follow-up, and it was limited to just the profession of physiotherapy service provision on the Saturday. As per most pilot studies, it was underpowered, and it was not known if it was cost-effective, as there was no economic evaluation with the pilot study. Following the 2 preliminary studies, an Australian survey was completed to report the provision of physiotherapy outside of regular business hours. This national survey revealed that only 30% of hospitals providing a subacute inpatient service had weekend physiotherapy.
So with all that in mind, it led to our main research question. So given all those preliminary studies, we wanted to know whether the provision of additional Saturday physio and occupational therapy, inpatient rehabilitation, improved clinical outcomes, and whether it was cost effective. And we received a grant from the NHMRC. It was a partnership grant between La Trobe University and Eastern Health. So the participants in our trial were all patients admitted for rehabilitation. So we only excluded GEM patients, geriatric evaluation and management patients. So it's important to note that there were no limits on cognition or language spoken. And it wasn't limited to a particular diagnostic group, it was all people admitted for rehabilitation. And it was at those 2 sites you can see in the photos, at the Angliss Hospital, the rehab ward, and also at Peter James Centre. The intervention we're looking at is that people either got the standard usual care, which was Monday to Friday, which is a full service of physio and occupational therapy, plus the allied health team, plus medical and nursing services, or a Monday to Saturday physiotherapy and occupational therapy intervention. So in other words, the people who got the Saturday allocated to the intervention on Saturday, they got additional physiotherapy and occupational therapy, but everything else was exactly the same from Monday to Friday. So our primary outcomes were functional independence, and this was done, we measured this with the FIM scale. FIM scale's got 18 items, which is looking at how independent people are with various activities of daily living, and it's scored from 18 to 126. So higher scores indicate that people are more independent functionally. And we used the EQ5D to measure quality of life, and we reported as an index score, utility score, from 0 to 1. The other primary outcome was length of stay, because that was, from our pilot data that suggested that was looking like that might be a positive outcome of this intervention. We're doing a health economic analysis, so we also had cost data, so from both a health service and also from a health system perspective. So we looked at admission costs, readmission costs during 30 days post-discharge, and then we followed people for up to 12 months post-discharge, including costs of readmission and community healthcare costs, and also, of course, including staff costs. The primary outcomes, in particular, the length of stay was accessed from the database from Eastern Health databases, and functional independence was measured by assessors who were blinded to which group people have been allocated to. So this is a rather busy slide, but it kind of paints the picture of how this trial was run and what happened. So the first thing to see is that we had almost 1,000 patients who were randomised individually to either receive the Monday to Saturday additional physiotherapy and occupational therapy, or to the Monday, the standard care, which is Monday to Friday therapy during rehabilitation. So there were 996 people allocated, and we had very good, our primary endpoint was at discharge, and so we had 94% follow-up at discharge, and then we followed people for 12 months, and at 12-month mark we still had about 80% follow-up. So it's a large trial, and patients are individually randomly allocated to the two groups. The participants were just what you'd expect in inpatient rehabilitation. They're older, there were more women than men, and we had a range of diagnostic groups. So you can see there's a mixture of the two key groups were people with orthopaedic conditions. So this would be post-fracture or post-joint, lower limb joint replacement mostly. And also we had quite a large number of people who'd had getting rehabilitation after having a stroke. So what did we find? The first thing we were looking at was length of stay. And we found that from the admission to discharge, there was likely a 2-day reduction in length of stay from 23 days to 21 days when comparing the intervention group, that's the Monday to Saturday group, to the Monday to Friday group. We can see there the confidence interval just brushes 0, so that's why I said likely. So we're not sure with 95% confidence, we'll be sure with about 94% confidence. So it's a likely 2-day reduction in length of stay. When we looked at from admission to discharge plus the 30 days post, it was a little bit clearer. And in that period from admission to 30 days post, there was a 3-day reduction in length of stay. In terms of the clinical outcomes, so this functional independence, so this is the FIN. So we can see here that we have the Monday to Saturday on the left-hand bar and Monday to Friday on the right-hand bar. And I suppose the first thing to note is they're pretty much the same at admission. And the big thing which I think is interesting is there was a huge jump from admission to discharge. And then essentially, if you look across for 12 months, there wasn't much difference thereafter. People basically maintained where they'd got to at discharge. So as an aside, it just tells you that people seem to make their most gains in functional independence during their inpatient rehabilitation stay, which is kind of, if I forget to comment on it later, I'll comment on it now. And it's often interesting because people often make the assumption, everybody's pushing to get people home. There's often this assumption that, I'll just get me home and then I'll be right once I'm in my home environment. And this kind of perhaps, it questions that assumption. For our particular trial, then we found that at discharge, our patients allocated to Monday to Saturday. Remember, this was in 2 days less, so it's on average 2 days less, that they had at a higher functional level at discharge. And that was maintained even at 6 months later. And then by 12 months, it was sort of starting to wash out somewhat. Now, one of the things that you might be thinking, or you should be thinking, is that the mean difference between the groups was pretty small. It was only a little bit more over 2 points in the FIM scale, which goes up to 128. So you should be asking, that might be statistically significant, but is it clinically significant? The way we looked at that was we looked at whether patients in one group were more likely to make a clinically important change in FIM of 22 points than the other group. And yes, they were. So people in the Monday to Saturday group were 17% more likely to achieve an MCID of FIM compared to the control group. So therefore, that made us think that it was, not only was it statistically significant, that it was likely clinically significant as well. When we looked at quality of life, we got a similar sort of picture. Again, you can see that it looked like there was a little bit of baseline variation. And when you see that most of the improvement in quality of life measured with the EQ5D was in that during the inpatient admission. And thereafter, our participants stayed pretty much the same for that 12 months. Again, there was a statistically significant increase in favour of the participants getting the additional weekend allied health therapy at discharge. But that statistical significance was starting to wash out even by 6 months. Again, the difference in the utility score was quite small. So we asked, is it clinically significant? And we found that the people getting the additional weekend therapy were 18% more likely to achieve a clinically important change in their EQ5D from admission to discharge. And again, that was also more likely at 6 months as well.
Okay, from an economic perspective, costs relating to the inpatient admission, as well as the cost of unplanned readmissions in the 30 days post-discharge, were examined. And by doing this, we were able to take a health service perspective. While the cost per week of the admission was higher for the Monday to Saturday group because they were receiving more intensive allied health intervention, this was offset by the cost of a reduction from a reduction in length of stay. So therefore, you see the costs for the Monday to Saturday group were $15,858 per admission, and for the Monday to Friday group, $17,532. So this difference, $1,673 cost saving for the Monday to Saturday group, did favour the intervention group, but it didn't achieve significance. And this is actually not uncommon with economic data when you think about how the data can in fact be skewed. You can have positive outliers, so those patients that have the extremely long admission for particular complications or reasons, but then when you come down, you can't have a negative cost. It can only come down to zero. So that skewing of the cost data means that it's not uncommon to not achieve significance with the cost difference between one group and another. Okay. In health economics, it's important that cost differences are reported in the context of clinical outcomes. So that's why it's called cost effectiveness. You're bringing together the cost and the effect. To achieve this, an incremental cost effectiveness ratio is calculated by dividing the difference in cost by the difference in the effect. Let me first of all explain the figure to make sure that we all are on the same page with what we're seeing there. You'll notice in this figure that the crossover point in the axes represents the control group or usual care. So what we've then got is the point estimate, and the point estimate comes down, you'll notice that down in that bottom right-hand quadrant, and that is talking about how different the intervention group is in comparison to the control group. So you'll see that if the point estimate is above the horizontal line, it is more costly. If it's below the horizontal line, it's less costly. And likewise, in reference to the vertical line, if it's to the right of the vertical line, you'll see that the intervention is more effective. And if it's to the left of the vertical line, you'll see that the intervention is less effective. And that's why that bottom right-hand quadrant is known as the dominant quadrant, because it's indicating that the intervention is less costly and more effective. I just want to talk about the confidence ellipses that are surrounding the point estimate. And these are those ellipses in the different colours, the orange, the blue and the purple. When you can consider a confidence interval, when you're looking at a one-dimensional mean difference, you're looking at the measure of variability from a one-dimensional perspective. But in health economics, when you're looking at cost effectiveness, it's really important that we are able to represent a two-dimensional picture, because the confidence ellipses are representing the variability in not just the cost, but also in the effect. And that's why we have to depict it with a two-dimensional view. Here you'll see the majority of the 50 and the 75% confidence ellipses are within that bottom right-hand quadrant, with most of the 95% confidence ellipses again within that bottom right-hand quadrant. So this is showing some really strong evidence that what we've got is a cost-effective intervention when we're looking at functional independence. We've got a little quote there from Nicholas Graves, who's the Professor of Health Economics for the Queensland University of Technology. And the quote is, "If you ever get an intervention that falls in this quadrant, it's almost criminal if it is not implemented." And that's just taking a really wide, I guess, societal perspective when we look at the scarcity of health resources. And if we know there's an intervention out there that's less costly and more effective, it is something that needs to be considered for implementation. Okay, the next one we're going to look at is the QALYs, the Quality Adjusted Life Years. So this is where we take the quality of life measure and it's converted, as Nick said, into a utility index, and that indicates quality adjusted life years. And what we wanted to do here in this figure is depict the cost effectiveness per QALY saved. So here we'll notice that we've got a cost saving of just over 41,000, and when we do our confidence intervals, which end up being quite large, but when we take it into a two-dimensional picture, we're able to see that the point estimate is again within that bottom right-hand quadrant, with replicating the functional outcomes with the 50 and the 75% confidence ellipses within that bottom right-hand quadrant, and again most of the 95% confidence ellipses within that bottom right-hand quadrant. So again, it's showing us that we've got an intervention with respect to quality adjusted life years that appears to be cost effective. Okay. The next slide, and apologies, it's a little bit busy, but I just want to give a bit of an overview for the 6 and 12-month follow-up. So as Nick noted in the methods, we followed our patients up at 6 months and 12 months post-discharge. But here we took a broader perspective. So rather than just considering readmissions to the primary health network, Eastern Health, we were able to look at additional data sources. So we had readmissions to Eastern Health, but we also got the data sources from Medicare and the Pharmaceutical Benefit Scheme to look at other health services utilised. We also included self-reported data. So speaking to the patients at 6 months and 12 months, we asked for recall of community and other health network services and admissions, as well as the use of formal and informal carers. So taking all of these data sources together, we went from a health service perspective to a health systems perspective, where we take all the different health services and we bring them together into a systems perspective. You'll see here at 6 months where we include the cost of the inpatient admission and all of the health system costs within the first 6 months. It actually was statistically significant in favour of the intervention group as a cost saving per patient over that broader 6-month period. When we then look at the cost difference for the 12-month period, so from the inpatient admission right through the 12 months, that difference between the two groups remained very similar, so around about 6,500 as it was at 6 months. Same difference remained at around 12 months, yet it was no longer statistically significant, but still telling the same story. We've just got a little picture down the bottom right-hand side where we've got the QALYs and the FIMs for 6 months and 12 months to demonstrate that the point estimate and the confidence ellipses remained mostly within that bottom right-hand quadrant at 6 months and 12 months. So it's giving a consistent story from the inpatient admission to follow up at 6 months and follow up at 12 months that we are providing a cost-effective intervention.
So they were our main results, but also we did some secondary analysis. And one of the things that we did, as Tash was saying, we took a health service perspective. So we looked at everyone admitted to the rehabilitation wards, no matter what their diagnosis. But a lot of clinicians and researchers often ask about specific diagnoses. They might work particularly in stroke, for example. So as a secondary analysis, we combined our data with another group which also looked at providing additional weekend therapy for stroke, and we combined their data on stroke with the patients in our group that had a stroke. This was important because our study wasn't powered sufficiently to do subgroup analysis, so it allowed us to ask, well, do we sort of get similar effects when we look at a particular patient group, a common patient group, for example, stroke? And what we found was, yes, it was sort of giving us the same story when we combined it with Coralie English's group, and adjusting for other factors such as hospital site. We found a 7.5-day reduction in length of stay at discharge, which was our criteria, or 4 weeks, which was in the English trial. So it was about the same time period for patients receiving additional weekend therapy. There are a few little differences, like our additional therapy was physio and OT, and their additional therapy was physio. So what do all these findings mean? What are the implications of our research? We found that providing additional therapy in physio and OT for rehabilitation in patients improved their functional outcomes and quality of life and reduced their length of stay. In other words, the patients who got the additional allied health therapy got better quicker. Now, the second finding about getting quicker, that was kind of what we hypothesised at the start. But you might remember when Tasha was talking about the pilot trial, we weren't sure about getting better as well. We thought, well, one of the risks would be that perhaps people would get discharged quicker, but they'd be at a lesser functional level. And what we actually found was that people got discharged not only on average 2 days quicker, but at that stage they're at a higher functional level. So it seemed to work. So why did it work? One explanation is that the physios and OTs were very good therapists, and what they do works. And that if the therapy someone provides works, and you provide a little bit more of it, that's almost providing support for that notion. So in a sense, we sort of got a dose response in that we compared 5 days of physio and OT to 6 days of physio and OT. Another explanation, another thing to consider, is that not having a 2-day break may have been one of the main reasons why our intervention worked. And we've got some of our secondary analysis provided support for that idea. We did on subgroups, we put accelerometers on them, and we found that people in inpatient rehabilitation are alarmingly inactive per day, and especially on the weekend. So I think the average number of steps per day during inpatient rehabilitation was around about, from memory, about 500 steps a day. And we found that for quite a number of people on an inpatient rehabilitation ward on a Sunday, that the number of them even had no steps, and that Sunday truly was a day of rest. And so we found that the intervention of providing additional Saturday therapy, we found that those groups in particular on the weekend were more physically active. And not only on the Saturday, they're also more physically active on the Sunday. So maybe it helped with not having that 2-day break, meant that our participants in the intervention group were more physically active over the weekend. Also, in a qualitative analysis we did when we talked to our participants in both groups, we found that they had very different attitudes and expectations about what would happen on the weekend. People who were in the control group, they actually felt that the weekend was a time for rest. And often they felt, in fact, they probably needed a bit more rest than they were getting on the weekend. Whereas when we talked to the people in the intervention group who got the therapy on the Saturday, they were saying, oh, that was actually a little bit annoying that there wasn't enough to do on the Sunday. So it kind of set up different expectations in the participants in the two arms of the trial. So the other part of it, so not only did it seem to work in terms of their clinical outcomes and length of stay, but we also found that it was very likely cost effective both from a health service and health systems perspectives. There were cost savings, and that was largely produced through the reduced length of stay to achieve better outcomes. And that was, we saw the lower quadrant there in the ICES. And so this has got some, we think it's got some potential benefits for the health service. So it would lead to improved patient flow. So if you're getting people discharged quicker at a higher functional rate, you should be able to admit more people, and it means that you're less likely to have bottlenecks in other parts of the health system, for example, in acute wards or even in ED. But the issue is, we think, who pays and who makes the savings. So we think that it's a strength of our study is it's a high quality trial with a low risk of bias. So therefore we're likely to think that what we found is true. We think there are some considerations for external validity in terms of generalisability. So we do need to remember that even though it was over 2 sites, our trial was completed in a single health service. So would it work just as well in other health services and other settings? I guess we've got a very preliminary answer to that in the data we combined on the stroke data, which I just talked about a few slides ago, which was completed in a couple of other health services. Also, we also need to remember this was particularly about inpatient rehabilitation. Would providing additional weekend allied health services work as well in acute services? And there's been a very large trial which has been completed. It has been completed, but the final results haven't been published yet. So it's a very large trial of weekend allied health services in 12 acute medical and surgical wards with more than 13,000 patients, led by Terry Haynes. So the first citation there is about the trial protocol, and also the preliminary results have been reported at a number of conferences, include the National Allied Health Conference. So their preliminary results reported at the conferences were that there was no effect on patient flow, that is length of stay, or in safety outcomes. So we seem to be getting a different finding in acute services from rehabilitation. So why might that be? We might speculate that allied health perhaps has a lesser role perhaps in the overall patient management in acute services, whereas it may have a more major role in rehabilitation services. So just sort of so there are our findings and what we kind of think about them, but we want to kind of change tack a little bit more and talk about what's happened since we finished the trial. So this is not the Skype, but this is really just to say this is what happened and this is what we've done. So we did publish in high impact medical journals. So the 2 main outcomes on the clinical outcomes and the cost effectiveness, the health economic analysis, were published in BMC Medicine. We also disseminated the results of our trial in our health service. So for example, we published in the Eastern Health Annual Research Report, got a nice glossy publication. We presented at the annual Eastern Health Research Forum in front of the board and also the CEO. And Casey Pierce won the award for the best presentation that year. However, there's a big but. But after all this work, the Saturday Rehabilitation Service has not, after the trial finished, it stopped, and it hasn't been implemented into practice at our health service. So I think it's really interesting to think about why that might be so. And there's sort of a couple of things that were thought of. And one thing is that the savings that Tash talked about accrue to the health service, but the cost of providing, the main cost of providing the service, that is staffing it with the allied health clinicians, that is at the level of the local budget. So there's sort of this mismatch. Also, there are other pressures in every health service. So, for example, we've had an ESS, which is an acronym about an annual efficiency saving for every department. And when that happens, of course, managers are under a lot of pressures to find a saving. And I suppose one of the things is to cut out the things which have come in lately or the additional services. So in terms, starting about the Hobbit, the journey, that's why we kind of talked about it being the journey there and back again. It's really and I think it's really an interesting case. It's not really about Eastern Health. I think this is sort of across the board, that it does take time to translate research into practice. And there's the much cited article which says that on average it takes 17 years to translate the results of research into practice. So we're really probably just at the start of our journey. And I think it's an interesting thing that, you know, as a researcher and as a team of researchers, it's really important to understand it's not just a matter of doing the research, building it and hoping they will come, because usually that doesn't happen, and that we need to think a little bit more deeply and carefully about the process of translating knowledge into practice. And so there are different, you know, and certainly I don't have any expertise in this area, but it's this being involved in this trial has made me think more a bit about it and wanting to learn more about it. And one example is the knowledge to action cycle, which is used quite a lot. And the one thing, with not being like an expert in it, but the thing that I picked up on that, one of the things in that knowledge to action cycle is being really aware and being able to assess the barriers to knowledge use. And then perhaps, and that's an important step in being able to translate and addressing those, and that's an important step in translating your research into practice. So I think those are the main findings. So I guess there are really two main messages. We think that we've got high quality evidence that providing an additional allied health service on Saturday works, helps get patients better quicker, and it's also cost effective. And the second part is really, it's an interesting case, we think, about the process of translating research into practice.
Thank you. Catherine, are you still there?
I am, hold on. There I am. Okay.
Hi. So I don't know if people have any questions. As I say, if you've got questions, there's a Q&A button at the bottom of the screen. Please type them in and we'll try and get them answered.
Well, I've got some questions here. Perhaps I'll get the ball rolling with the first one while perhaps other people are having a think and tapping in their questions. So this trial focused on additional Saturday physio and OT. Is there evidence for the other allied health disciplines such as social work, speech pathology, dietetics to provide additional Saturday services? And if there is no evidence, what do the researchers hypothesise might be the case for those professions?
I'm happy to take that one. So it's actually, for the other disciplines, it's almost going back to where we were at the pilot stage when we looked at should physiotherapy be provided on a Saturday. When we did stop and look at the literature, what was available, just from a literature search, not a systematic review, there was again a small number of poor quality papers out there that had even examined social work, speech pathology and dietetics over the weekend as well. But again, poor quality and a low number. So it is actually inconclusive from a literature perspective. Again, having been through this process over the last number of years, it would be hypothesised that there may be value, again, whether it's in terms of length of stay or patient outcomes, but if you've got proven interventions that can impact patient outcomes, that there may be a dose-response relationship with the other disciplines as well, but at this stage it is unknown.
Thank you. I'm just checking up on our questions. We still haven't got any popping up from our participants. So get on your keyboards, people, and type in some. Oh, hang on. Oh, we've got one. Penny. Thank you, Penny. What was the rationale for choosing 6 over 7 day therapy? Do you have plans to implement 7 day therapy? Nick.
No. I think that the rationale for using 6 days was because from the systematic review we did that there seemed to be there was the preliminary evidence, such as it was at that stage, suggested that 6 days might have, that seemed to be pointing a little bit more in favour of the 6 days, and it was a little bit more equivocal with the 7 days from memory. There were a few sort of contrary findings for the 7 days. And that's why we did that with the pilot study, and because the results of the pilot study were positive for the 6 days, that's why we did the 6 days for the big trial. And there's also, I mean, it's not evidence-based at all, but it's that feeling, I kind of still feel in myself like there's something about having a day of rest, but, you know, I think that's a cultural hang-up I've got, that Sunday is probably a little bit of a different day. Do you want to add anything to that?
No, I actually agree. So, and the other perspective we took is that jumping from 5 days to 7 days meant that you'd always question whether is it the jump of 1 extra day or 2 extra days that resulted in any findings. So the concept was also that if we incrementally increase 1 day at a time, you can find out at what point were those differences made, and at what point is it superfluous to have the additional therapy. So in an ideal world, we'd love to receive competitive grant funding to then go and examine from the 6 days to the 7 days. But in fact, I think it's there's greater importance on actually translating the 6 day finding before we started to do new fresh research to examine the 7 days. Thank you. Penny.
All right, I've got another question here from Andrew Zerner, who's a senior manager of physio in Central Adelaide. The English trial included a third arm, increased physio Monday to Friday. Similar outcomes, more cost effective than weekends from memory. Should the conclusion of your trial be that increased rehab dose provided any time over 7 days improves outcomes and reduces length of stay?
That's a really good question, and we don't know. That's the answer. We can only hypothesise and then go forward and test the hypotheses. That is it the additional therapy over the 7 days, so therefore it could be actually inserted Monday to Friday as an additional session, or does it need to be over the weekend? And that's where you need to break down and try and work out what was the explanation that caused the difference. Was it that you didn't have a chance for 2 days of inactivity and a decline in your functional status, which is why it was crucial to be over the weekend? Or was it a pure dose-response relationship? And that's one that we can't answer, but it's a really good question because there's cost implications. If you look at our EBA and you look at loading over the weekends, there's other implications as well. If you're doing it as a trial, you've got to get, we had a lot of people working on the weekends who worked full-time elsewhere. They came in and provided the extra service. If it was during the week from Monday to Friday, you also need to consider about workforce redesign. And the other issue that we had is a lot of the rehab centres offer very comprehensive programs where you're receiving physiotherapy once or twice a day, OT once or twice a day, speech, dietetics, whatever else is needed. And we actually found that for some patient populations, particularly the complex ones, for example, stroke, actually didn't have capacity for an extra session within the day. So there was a lot of, considerations either way, but it's a really valid point that's very worthy of examining. Is it pure dose response, or is it in fact about placing it over the weekend and looking at stopping that decline of functional status with 2 days inactivity?
Thank you. Another question here from Lynn Wakefield. Was the type of weekend therapy the same as during the week or not?
Yes, it was exactly the same. So it was done in the same way. So at that stage, at those sites, the participants went down to the gym. So it was done in a sort of an open setting, their rehab, and we did it exactly the same on the weekend. So we used a portering service, and also it was done so it was basically set up so that people had to get exactly the same as what they would get Monday to Friday on the Saturday. So if they normally got 2 sessions of physio, like if they're following a stroke, then that would happen on the Saturday as well. Do you want to add anything to that?
And just, it was a handover. So the regular Monday to Friday therapist would then provide a handover for the Saturday. So there was a continuation. It wasn't expected that it was a babysitting service where somebody fresh came in, did a fresh assessment or fresh whatever. It was a continuation of what had been done Monday to Friday, where the Saturday therapists were expected to progress and prolong the therapy program that was already being done. So it was still goal-directed, progressive, individualised therapy that was provided. Yeah.
Good. I haven't got another question popping up on my screen here, so I'm going to ask another one. I'm going to surprise our researchers a bit. I'm going to ask them one that they're not expecting. I'm interested in hearing from Tash, and Nick has talked a little bit about the experience of trying to translate evidence into practice here at Eastern Health. That since the completion of this research, I'm aware that Tash has moved health services from one to another. It might be just interesting to hear whether you've had a similar experience, Tash, at the health service where you currently are, or whether you've got any different insights in terms of how it's been received there.
Which is a private health service.
Yep. So I manage the services for Cabrini Health, physio services, and it was really interesting. And all health services I've learnt over the last number of years, public, private, they all have financial pressures, and that's just part of, you know, providing a service and effectively being a business that needs to be viable. So it was really interesting at Cabrini. I remember when I first started 6 years ago in the middle of the PhD, I had the opportunity to have some time with our CEO, who's still there at the moment. And he asked about, you know, have I considered doing any benchmarking, or have I considered doing anything to look at our rehab services at Cabrini and compare outside? And so thankfully I was able to talk about the systematic review as a really good benchmarking tool, the national survey, and then also our Saturday services. So at the time, all the results were coming in very, very positive. So I was able to talk about that. And he was, you know, very receptive and open to it. But again, there's a difference to having that real warmth and open and actually implementing. Thankfully, we actually at the time provided a 7-day service at Cabrini Rehab Services, and then it went through a bit of a restructure based on patient feedback and a number of different factors, where it was actually decided that we were going to align to the research and provide a comprehensive 6-day service rather than providing a 7-day service that was a bit reduced over the weekends for the physiotherapy. We don't provide OT on the weekends, which again is something that I'd love to examine at Cabrini, because I think that's a you know, very worthy discussion. But I think because my director of allied health at Cabrini also came across from Eastern Health, where the research was embedded, there was that real depth and belief and understanding of the research that gone on, the rigour around it and the robust results, so that when we talked about ensuring that we were able to offer a robust 6-day service, there wasn't the resistance, there wasn't any hesitation that we could actually move from a 7-day service where it was pretty light on the Saturday and Sunday into a robust 6-day service that was aligned, at least from the physio perspective, to what the research findings were. But again, that's a particular environment that happened to be receptive, and I know that yeah, a lot of that also comes to relationships and budgets and a lot of external factors as well.
All right. Has anybody else got any questions? If not, this might be a good point at which to bring Sarah back in to wrap up.
Yeah. Okay. Can I just thank Catherine, Nick and Tash. Thank you very much. Very interesting. As I said, I've recorded today's session, so I'll send the link out to anyone who registered, and I'll put it up on our website as well. And as I say, take a look at the Health Services Research Association website, and we'll have some more webinars coming up the next month or two, so keep an eye on that. Thank you very much, guys. Thank you.
Thank you.
Thank you.
Yeah, thanks for the opportunity.
Great. Thank you.